Hi, my name is Fernando Althabe. I'm from Buenos Aires, Argentina, working at the Institute for Clinical Effectiveness and Health Policy in Buenos Aires. I'm going to summarize the results of the Antenatal Corticosteroids trial conducted within the Global Network for Women's and Children's Health Research funded by NICUD. As a summary, this was a trial conducted in 6 countries, a cluster trial carried out in 102 clusters that enrolled in about 18 months of intervention period, 100,000 women and babies. And the trial was done to address whether a complex intervention that provided and facilitated the use of steroids for women at high risk of preterm birth actually reduced neonatal mortality. So the 3 questions that were addressed were, first, if it was feasible under routine conditions to scale up antenatal steroids at all levels of care in low and middle income countries. And this was mainly motivated because the use of steroids in these countries was usually very low, conversely to what happens in high income countries. Several barriers are actually reasons for this low use. The second is that it's not only important to increase the use of steroids, but also we needed to ratify whether the beneficial effects observed in the efficacy trials conducted in high and middle-income countries were also achievable in this kind of settings. And lastly, we needed also to verify whether the antenatal steroids were safe for the mothers and their babies in this kind of settings. These were the results. Among the subgroup of babies, of preterm babies, we did not use gestational age as the cutoff point. We used birth weight because we did not have a good assessment of gestational age. We have observed in those small babies that in the intervention group implementing this complex intervention and providing steroids compared to the control group, neonatal deaths did not decreased. So did stillbirths, as we expected, but maternal infection was increased. Surprisingly and very unfortunately, among all births, we found that there was a statistically significant 11% increase in neonatal mortality and in stillbirths, and a 47% increase in maternal infection as well. So, and this was clearly a surprise. We will try to do an interpretation of each of these findings. First, regarding the absence of positive effect on neonatal mortality, first, we can say that although we increased the use of steroids in the intervention group to 45% of these small babies compared to 10% in the control group, not even half of them actually receive steroids. So perhaps the absence of effect could have been caused by that. Second, 50% of these babies were late preterms in which still there is no evidence of a clear reduction in neonatal mortality. Also, that's something that we hypothesize. Perhaps there is a need of better neonatal care capabilities just to detect this beneficial of these benefits of steroids. And finally, well, perhaps in this kind of settings, the newborns are suffering of other comorbidities, and we know that infection in these settings, mainly in Africa and in Asia, are, let's say, a substantial cause of deaths in preterm babies. However, the most problematic findings are the harmful effects in the overall population. So we must acknowledge that there was a huge overtreatment of women that were detected as having high risk for preterm birth. Only 16% of them delivered a small baby or a preterm baby. And so antenatal steroids given to the wrong population perhaps increase the, let's say, morbidity and mortality, perhaps a higher susceptibility to infection in this particular group. Or perhaps in this complex intervention that included several components, there was a worsening in the quality of care in the intervention group compared to the control group. We actually don't know this, but we are sure that further research in low research settings are needed to find out whether steroids are actually able to be scaled up globally. Thank you.